So we're really excited to be here as we conclude the 20th anniversary of the GU Cancer Symposiums with GU Oncology Now, sort of talking about some updates from the last day, always the last day of the symposium, the kidney cancer day. And I would argue, maybe because I treat all the kidney cancer, that I think this was probably the most exciting day of the meeting. And we saw some really impressive data on long-term follow-up, as well as some exciting adjuvant data. So I think before we go into the metastatic disease, let's really focus on the adjuvant setting, right? Because that's going to be where we can hopefully cure patients and put us out of a job. So we had two nice updates on adjuvant. We had KEYNOTE-564 and we had CheckMate 914. So Libby, I guess, what are your thoughts about this data now as you put it into context?
Yeah, well, it's a great time to be a genitourinary medical oncologist. We have better tools than, frankly, I imagined when I was a trainee that I'd have to offer patients with advanced or with high-risk kidney cancer. And so it was fantastic to see that KEYNOTE-564 has demonstrated benefit to overall survival for patients receiving pembrolizumab in the adjuvant setting. And it really cements it as the greatest innovation that medical oncology has had to offer to patients with more locally advanced kidney cancer.
Yeah, I mean, Tony even alluded to, right? This is like since 1973, how many patients have been in trials, and this is the first trial to show any sort of overall survival benefit. But I guess, Alan, when you want to talk about like what patients sort of fit into that
Right.
trial.
I think, when the first data set came out a couple of years ago, I think there was still, a third of people were, saying that they would do it. A third would say they would do it for select populations, and a third of patients, people would say that they wouldn't do it at all. But I think now that you actually have overall survival as the benchmark that has been met, I don't see how you couldn't at least talk to the patient. I can understand if the patient has, a lower risk, maybe T2 or maybe T3, you could perhaps argue that that patient might not be at that highest risk population. But, in the melanoma world, the patients have been getting adjuvant immunotherapy for several years without overall survival advantage. So it always confused me why it was such a tough decision in kidney cancer, where patients really do desire the opportunity to have a cure. Sure, 50% of patients are probably overtreated in this population, and they're probably cured with surgery, but that's a high percentage of patients that aren't cured with surgery, and they should get some adjuvant therapy.
Yeah, no, absolutely. I mean, I think of all of the studies that were presented at the meeting, hands down, the data for 564 were the most impactful. This is a landmark time across all solid tumor malignancies and hematologic malignancies, I guess. We have demonstrated that an adjuvant immunotherapy actually improves overall survival. So this is a huge win for our patients, and something that I think, can be even applied into practice, next week when you're seeing your patients in the clinic. So I think it's really highly relevant. I think the biggest thing that people grapple with around the receipt of therapy, as I believe it, is patient selection, and are we selecting the right patients that do have the highest risk? Because the way that we treat people in the front line is a little bit different. Or in the adjuvant setting now with monotherapy is different than our combination IO regimens in frontline. So there's this grappling of I'm over-treating some, I'm under-treating some, but there's a group that's in the sweet spot, and how can we better define that group? But I think right now, in the absence of a biomarker, we really have to align with the eligibility criteria for the trial, which is, T2 grade 4, T3, T4, M1 NED, and N1 patients. So, but I think these data are really landmark. I think they're absolutely practice changing.
For clear cell, I think is a key point. Right?
Clear
I
cell.
mean, we really want the same thing to happen in our papillary and chromophobe clear cell. And again, the M1AD, that's a very small subset, but really pronounced benefit from looking at DFS.
Yeah.
Uniquely, it was like those early progressors within that first year. I mean, to your point, that patient selection is sort of a key aspect. And we've had a lot of other trials that have been presented with adjuvant therapy. We had the PROSPER trial, like a perioperative nivolumab. We had a trial looking at adjuvant atezolizumab. We had 6 months in Nivo-Ipi. We saw that results from CheckMate 904. And then Dr. Mozart presented updates from the second cohort, looking at 6 months of nivolumab versus placebo.
Yeah. I think the big question is, are those patients that you're not curing in first line or in adjuvant, are they the same patients that can you actually cure them when they get to metastatic? And I don't know that we know the answer to that, because if those patients would potentially evolve to become favorable risk, and we know the profiles for those individuals. So I don't know that we know that you can absolutely save the patients that are going to respond adjuvantly when they're metastatic. I don't think we can say that they're the same population, so just save it for later, you know?
Yeah, and it's tough though, because because we all have those intellectual questions though, and you know, in oncology, certainly with our patients who have advanced disease, we're playing a chess game the whole time. From the moment we meet that patient, we're trying to figure out how to position things perfectly. But you know, so it is hard to not know that, but it seems pretty clear though, you know, adjuvant pembrolizumab has great value and should be offered, and adjuvant nivolumab, really, we don't have the justification to offer that right now. And it was interesting to think through, you know, because of some of the earlier incredible efforts, but disappointments in some of the other trials, like Prosper, for example. I think there has been a lot of theorizing about why that trial was not positive. And today, seeing that 914 was negative also kind of raises questions. Well, is it just design? Is it the molecule? Is it the populations being, I mean, there's some very hypothesis generating.
Right, I think it leaves a lot of unanswered questions too. I think, what do you guys think about PD-L1 versus PD-1, right? Or do we really think there's a difference between nivolumab and pembrolizumab? Was it the 6 months versus 12 months?
Yeah.
No, I absolutely agree with you, Alan. I think it's multifactorial. I do think PD-L1 and PD-1 aren't created equal in kidney cancer. I think there's differences. And then as we think about, you know, 914, it's always easy to play Monday morning quarterback and like look in hindsight and say, well, the trial should have been designed like this, you know, but they included T1 patients. They excluded M1 NED patients, which are going to drive events and be higher risk. It was 6 months of therapy. The Nivo monotherapy was grossly underpowered. Yeah. And so it's hard to say, you know, that trial was, you know, I think there were design issues there, eligibility patient criteria issues there.
In some way, it's sort of more about like, yes, that trial is negative, but I think there are some of us who are still in the place of saying like, well, is that product, are we convinced that product really couldn't ever affect it? I don't think we're necessarily convinced, but we have to see the data speaks for itself. So that's kind of where things stand today, I guess.
Yeah, I mean, to that point, I think we should really commend like thinking differently, right? I mean,
yeah.
a year of pembro, the year of immunotherapy is relatively arbitrary. Like, why do we do a year?
Agree.
So, I mean, I was actually really excited when we heard about the CheckMate 914. I'm like, this is fantastic. You know, 6 months is so much better for our patients. Yeah. Maybe they have lower toxicities.
Yeah,
you know,
lower
unfortunately,
healthcare
it didn't
costs.
pan out. So now it's easy to look back and say, well, it's obviously maybe because it's 6 months. But at the time, I was actually really excited for that approach. Like, is this gonna be?
I don't really think it's the duration either, because if you look at the DFS curves for Nivo, it's right along with the control arm, whereas with KEYNOTE-564, it actually separates within that first 6 months. So what does that really tell us there? And especially the receptor occupancy studies, right? If you stopped at 6 months, do you think that receptor is actually off at 12 months?
That target binding occupancy is high for a long time.
I think this data is awesome. Clearly, we're helping some of our patients, but there are still some patients that you know, progress, and I think we can still do better in the adjuvant setting. And Brad, you've been coordinating a study through the cooperative groups, Strike, which is going to integrate IO-TKI, short-term TKI, in the adjuvant space. So I think we need to continue to support these studies to kind of capture that population.
Yeah. This is for sure the backbone that we need to study on, and TKI should be included, and I think HIF2 alpha should be also studied, and it already is.
Yeah.
Yeah, we're greedy, but we see this great study. Like, okay, how do we do better, right?
Right.
We want to do better for our patients.
I was saying we owe it
right?
to our patients. We need to do our best for them. They're our purpose.
So I agree. I'm really excited. Like now, I think we have a solid foundation on which we can build upon, right?
Finally.
Like we have a trial which showed an OS benefit, and so let's take it and run with it, and let's try to do better. Find the right patients, you know, maybe there's patients we don't need. We can do studies, look at what we have, and then, you know, as we do that, like, let's try to add like more. Let's improve that. You know, right now there's a 5% improvement in survival at 4 years. Let's make it 8%, 10%, right? Let's shoot higher. So really, really excited.
And we, you know, in kidney cancer, we're not very good with the biomarker, unfortunately, and ctDNA is underperforming currently with commercial assays. So I'm really glad that your trial is going to be looking into some really interesting correlatives to try to see what we can do in that space.
Yeah, absolutely.
Push the needle forward.
Yes, I mean, I agree. I agree with Rana. I think that was probably one of the most impactful trials, and you know, because it's already approved, it's gonna be. I think it will change the way we counsel our patients, though, right? I mean,
I agree. It will make those conversations much simpler, I think, and I just think less burdensome for the patient, because we owe it to them to provide them comprehensive counseling and to make sure they have all the information they need to make an as informed decision as possible. And when we did not have OS benefit, that was a lot to take in, given the risks of these agents. But now it will be a relief, I think, on our part and theirs, and there are people who love them, to know that they could be embarking on something with proven value that they can really conceive and embrace.
yeah, I mean, I think we saw that nice stuff from Dina Battle, and like, what do patients think about this? I think, you know, it's disease-free survival. It's like, we think about it, even though sometimes I even get like, what does that exactly mean? But overall survival is so clear, right? Like, by doing this for a year, hopefully you have a better chance of being alive in 4 years than not. So I think it sort of settles the debate in my mind with all these negative trials, like, oh, what do we do? But I think
No, totally impactful.
But as we talked about, unfortunately, it doesn't always work, right? I mean, we still have patients that are going to relapse, and so, you know, what do we do next? And so we've had, obviously, you know, this sort of phase 3 after phase 3 trial for a while, and now we're actually seeing long-term follow-up.